Good morning. My name is Joe Kiani. I'm founder and CEO of Masimo. I began Masimo in 1989. I remember being at World Congress of Anesthesia in 1996 when we introduced signal extraction technology, pulse oximetry, the first pulse oximeter that could work through motion and low perfusion. And that was in Sydney. In 2008, we were with you in Africa, in South Africa, when we introduced our non-invasive hemoglobin technology. And Sign of Times, we're here virtually, I think from all over the world. Joining me here, Dr. Matta, Dr. Mueller, and Dr. Zacharowski, which I'm honored and thrilled to have with me, to introduce to you our new Masimo Safety Net Alert. It's a system that I'm extremely proud of. It not only has our SET pulse oximeter technology, which has been proven to reduce retinopathy prematurity in neonates, help detect CCHD in newborns, and help save lives in the hospital, especially post-surgical wards where patients are given opioids. But we have taken that technology, we've made it untethered, wearable, working with a smartphone app so that patients can now be monitored at home when they're taking opioids, prescription or illicit, and hopefully save many, many lives. Basil, would you show a few slides I just wanted to show before I hand the mic to you guys? Thank you. So, a 10-year study at Dartmouth-Hitchcock showed that a group of patients in the post-surgical ward that were given opioids had no more brain damage, no more death from opioid-induced respiratory depression. In contrast, the group that didn't, unfortunately, had several deaths. They also showed that they saved $7 million a year after the expense of the technology because they reduced rapid response team activation by 60% and ICU transfers by 50%. And that technology, as you see, was using our hospital-based products, either the Radical, Root, Radius VSM, or Radius, with patient safety net surveillance system. Next slide, please. We have taken that same technology and put it in a simple wearable device that has a battery life of 4 days for continuous use, the full set performance. Next slide, please. And then the information, the pulse oximeter data, goes to either the Android or the Apple phones. And if the oxygen saturation level drops below a level that's dangerous, an alarm will go off on the smartphone and a medical hub, a home medical hub that the patients hopefully will awaken. But if they don't wake up, they can have preset it to notify users, family, friends, anyone that they want with their location so that they can hopefully come and revive them. In hospitals, it's estimated between 10 to 50,000 people die of opioid overdose worldwide annually. In home, the number is over 100,000 a year. So I'm really happy to let you know we have now launched this technology in Western Europe. This is the first week it is out, and I hope we can save a lot of lives with this and do some good. So with that, I'm gonna thank you for your time. Thank you for joining us, and ask Dr. Matta to present. Thank you. Dr. Matta, is your mic off? Thank you.
From the second he died, that's the first thing I questioned is, where is the fairness? You know, Parker had everything going for him. He'd just newly been married, he was happy. He just always wanted to be a husband and a dad. He just couldn't wait to have kids. And when he was gone, I had no idea. You can die when you're taking these painkillers.
Parker was a healthy 21-year-old. He had his surgery, this is important, he had the surgery done the same day as his sister. I sent them both home with the same medication. Parker took less.
We had a really good night. We put our first Christmas tree up that night. I'm not really sure why we did it so early, but I look back now and I'm grateful for it.
Went to bed, he woke up about 3 or 4. He took a pain medicine then because it was starting to hurt. The other medicine had worn off.
I woke up before him, and so I just walked past the bed and over to the vanity, and I was telling him, I just told him, Parker, it's time to get up, you know, we gotta go. And he was gone already.
He's buried just down the road, so sometimes when I go by, it just sucks my breath away.
If you're on one of our floors and we're giving you pain medication, we insist that you are monitored 24 hours a day. And the second that they leave the hospital or they discharge, we pull that monitor off and say goodbye.
I've had so-and-so's sister or uncle or aunt call me personally and say, you know, what would you do differently? My son needs a tonsillectomy, or my daughter's going in. Make sure your doctor gives you a monitor.
He had people around him almost constantly, very functional, very bright people, a lot of support, and that couldn't save him. A machine could have. No, a machine that is easy to use would have, not could.
It wasn't hard for me to find out about all these other deaths, all these near misses.
They're taking a medicine we told them to take, and it has potentially very dangerous side effects. It's just it's a blind spot, and society is paying a heavy price for it.
Why is this not being told to people? This can be prevented.
So, good afternoon. My name is Zacharowski, and I'm the current president of the European Society of Anaesthesiology and Intensive Care. And I'm practicing anesthesiology and intensive care at the University Hospital in Frankfurt. As leaders in anesthesiology and intensive care medicine, we are constantly working to improve patient outcome. That's what matters most. One of our major roles in managing pain and in combining and monitoring anesthesia techniques to optimize patients' outcome through balancing regional and general anesthesia for opioid-sparing anesthesia and analgesia while improving intraoperative patient comfort and optimizing postoperative analgesia. So stress-free anesthesia is very important for patient outcome. While anesthesiological preparation starts already weeks prior to planned surgery, many patients are in hospital. Many of our patients have comorbidities, chronic diseases, and unknown home and health situations where the combination of the opioids given during surgery and prescribed after surgery could create a risk for them. But we largely do not have these data, as we often do not have patient data post the post-operative and post-patient discharge. So while we know failure to rescue is a reality in hospital, it is not clear how many lives need rescue post-discharge. Yet we do know lives are lost every year. Our expertise continues and is needed beyond the hospital walls. As experts in pain management and anesthesia, considering the role of monitoring at home to provide alerts if a patient needs rescue, and to begin to understand our patient and patient data after they leave our care. Healthcare is expanding beyond the hospital, as is the role of anesthesiologists and intensivists. Our expertise matters, and quality monitoring and data matters as our next frontier of patient safety responsibility.
Good morning, everybody, and thank you for asking me to contribute to this panel. And it's a real privilege to do so, and also it's a privilege to know that I'm in the same virtual room with many friends and colleagues from previous times. My name is Mike Durkin, and in a previous life I have been a consultant in anaesthesia and critical care in the UK and in North America at Yale University School of Medicine. And in recent times, I have moved across to help support and develop systems for patient safety, particularly in a role as the NHS National Director for Patient Safety in the UK, and now helping support WHO in a global collaborative movement to support patient safety. Also, I'm privileged to sit on the Patient Safety Movement Foundation board in the US. I think is probably as equally important, and maybe more important, is that of implementation of change. We have lots of great ideas, we have lots of great systems, we have lots of great experts, and we have lots of willing patients to help us and willing industry partners to support us. But it's the interventions and the implementation of those interventions that are really key for me in this element. And none more so than out of hospital interventions and implementation of change for improvement. And it's the out of hospital element that is absolutely key. We are experts in anesthesia, in monitoring, and we are experts in how we can persuade many of our other hospital colleagues to use monitoring systems now, particularly the use of simple non-invasive tools. We need to move this out of hospital. We need to make it available for our primary care colleagues, for our patients, and for our management systems, so that they are equally employed and deployed when necessary, and none more so, I think, in the post-operative phase, where opioid medications are of key importance in enabling a faster and speedier recovery. So I think that's enough for me. I tend to witter on if I carry on too long, but I think for me the most important thing is to maintain this approach that anesthesia leads the way. Anesthesia has always led the way in terms of change and improvement, and it's been brave to do so. And I think we have a great opportunity now to move the concept of in-hospital monitoring now to out-of-hospital monitoring, and use all the data techniques and digitally enabled systems to be able to do that. Thank you very much for letting me join you this morning, and I hope the panel also equally does well, but also I hope the conference goes well for you all as well. And please check up on us in the global movement for improving patient safety. Thank you very much for listening.
Yeah.
Good afternoon, everybody.
कर दो ना, मुझे समझ में नहीं आ रहा क्या कह रहे हो आप।
अरे समझने क्या नहीं आ रहा।
कौन है
अपने 3 month का प्लान है, अपने लैंडलाइन नंबर है कोई 3 month का प्लान।
Hello, good afternoon, everybody. My name is Conrad Mueller. I'm a pediatric surgeon. I'm the president of the foundation of the University Children's Hospital of Basil. And as pediatrician and as pediatric surgeon, we live this vision already together at home. Next slide, please. Basil, yeah. But we have a gap, and you see it here. When we are staying in the theater, our children are fantastic monitored. Then they go to the recovery room, and then they go to the ward, still monitored, and then they go home. There's a gap. Next slide, please. Why we should close this gap? Pediatric surgery is 80% daycare surgery. You know how it is because you are an anesthetist. We as surgeons, we operate 8 to 10 children a day. And then at 4 o'clock, we go to the parents and we tell them often, mostly, there's no problem. And then the patients, the parents, the young parents are going home. During the whole hospital stay, the children were monitored. The parents are often young, and it's often the first time they bring their baby to the hospital. And it's the first time that they take the baby at home after anesthesia. They feel insecure. 90% of the parents are very happy when they phone them the next day and ask them how was the first night at home. And often, if they're really open, they say it was hard because they were feeling they are really alone. After a day in a hospital with all the fears, what can happen about the baby, they had a night with all the fears, what can happen about the baby at home. Next slide, please. Why? Children after daycare surgery often vomit at home due to the opioids given during the intervention. And then the parents are feeling very insecure. A big problem we see often, the pain management at home is often insufficient because the parents fear to harm the kids. So they give only half of the dose or they give even nothing. And there is the problem of the silent disease. Yes, this is a very rare problem, but it can happen that we don't know the disease before the child goes to intervention. For example, a cardiomyopathy. So what we should do, start the monitoring in the hospital. Start it with this tool when the child is already in the theater, goes to the recovery room and goes with this monitor system at home. The child, there will be no more a gap. And from theater to home, you stay close and we stay close and we are together at home. Thank you very much.
Dr. Matta, we can't hear you.
Okay, I'm gonna share my screen. Can you all hear me?
Yes.
Excellent. Well, good afternoon. I'm Basil Matta, the Senior Medical Director for Masimo and the Consultant in Anesthesia and Critical Care at Cambridge University Hospitals. Now, for the last 20 years, I've looked after, maybe more than 20 years actually, I've looked after patients who've suffered and been critically ill. And my drive has always been to improve outcome for these patients. And one of the most important developments that I've seen in the last few years is how easy and reliable non-invasive technology has become. We're able now to monitor patients, not just in the ICU, but on the floor, and even take them monitored at home remotely. We can keep an eye on them remotely. And that allows us to prevent the patients from deteriorating and readmitting them into the intensive care. Now, you've heard Joe, Kai, Mike, and Conrad. You've also heard Parker's story. I'm sure some of you have heard some of these stories at odds every now and then in the newspapers from friends. And we really must now appreciate how serious the world is facing a problem with opioid-induced respiratory depression. Now, I know as clinicians, we want our patients to be safe, we want them to be pain-free, but also we want them to be free from harmful effects that the drugs we prescribe can cause. Now, the choice we're faced with shouldn't be a patient in pain with no opioids. Surely, when there are new drugs come on the market in the future that don't involve opioids, maybe we can use those. But for the time being, the choice is having a patient in pain or having a patient with opioids and not being able to monitor them and watch out for side effects. And really now with the availability of Masimo, safety net alert, we have a hospital grade technology that is proven to work through motion, work through low perfusion, that gives us reliable alarms and reliable readings that keeps us sort of comfortable in that we are now watching our patients from a distance and making sure no harm comes to them. So really, I suppose what I'm asking you to do is to reflect on what you've seen today and ask yourself, why wouldn't I recommend to my patients this device that is non-invasive, that's reliable, and are relatively cheap to keep them safe? Well, thank you very much for listening.
Thank you so much, Dr. Matta, Dr. Mueller. It was really nice having Dr. Zacharowski and Dr. Durkin with us. Do we have time for questions? Do we have questions that we can take?
We have time for questions. I don't know.
Then if not, maybe Dr. Mueller, any closing remarks?
My closing remarks is I think this tool is fantastic, and it will be for some of the patient and for some of the family, it will really help to go through the nights after they were in the hospitals. And I think somebody was telling it before in the film, and you see it, because you stay in the hospital, you have all this equipment, and suddenly there is the nurse coming, the doctor coming, and there's discharge. And this discharge time, we are open, we are brave, we tell it. It's often very short. And then the patient goes home and there's no more monitoring. And I think this should be changed. Thank you.
Thank you. Thank you so much. Dr. Matta, any closing remarks?
Well, really, only, Joe, is that we need to think hard why we wouldn't use such a device. It's easy, it's non-invasive, it's reliable. So yes, that would be my remark. We need to be pushing this out and encouraging people to use it.
Thank you. Thank you very much. I want to thank everyone for joining. My closing remarks is when I started Masimo as an engineer, and I hope to solve the motion artifact problem with pulse oximetry, there are a lot I could not have predicted. I could have not predicted CCHD detection with our technology or reduction of ROP, but I did predict that if we made a product that was reliable, didn't have all the false alarms, it could help patients on the general floor not have opioid related deaths. And I did not know that the problem was even bigger at home. And I used to think opioid overdose is something that happens to people who abuse opioids. To learn that of the 70,000 people that die in the US, 20,000 of them are from prescription opioids, like Parker, a healthy 21-year-old, 6'3", healthy, takes half the dose and doesn't wake up. And the numbers are huge in Europe. 2,000 people in the UK, several thousand in Germany, every year die of this. And to now finally have a solution that can be wearable and be taken home. I remember when I started Masimo, our first pulse oximeter with signal extraction technology consumed nearly 4,000 milliwatts. This technology is under 20 milliwatts now and can be wearable with a battery that lasts 4 days. So I hope together we make a big difference. I know anesthesiologists paved the way for patient safety. I know you guys reduce anesthesia-related brain damage and death from 1 in 10,000 to 1 in over 2 million. And I hope with your leadership, we can do that for people that take opioids at home. So thank you all for joining. I hope at the next WCA, I guess in Singapore, we'll see each other in person. Thank you so much. Have a wonderful day.